what I'm going to talk today is about a number of molecular imaging tools, but as a way of introduction, and I'm hoping I get to see you guys over and over again over the years, I'm a radiologist, and I'm in the business of making pretty pictures, okay? And you may be wondering, why is a radiologist here at this conference? And for a living, I diagnose people in pain, and I specifically have trained in musculoskeletal MRI. So virtually every order that comes in for me to read, everyone is in pain, and I have to find a pain generator in those studies. And I would say more than half the time, I cannot give you an accurate answer why, okay? About 30% of the time, I might be able to maybe give you an accurate answer. And so I have to go home every night knowing I did a disservice to a majority of the patients that I saw, And so what motivates me is to find a better way to image nociception and pain. So the outline of my talk, I'm going to explain where I'm kind of coming from, see what my motivation is. And then I'm going to explain how we can exploit pain biomarkers as a way of imaging, and then show you some technique and examples that are going in my lab as well as some of my colleagues' labs at Stanford. So first, the ugly truth, and I'm going to have you participate in this exercise as well. This is an example of an MRI of the neck in two different people. Patient A is on your left, patient B is on your right. We're taking a sagittal image through the neck, and both of them have presented with pain. But which of these two patients is complaining of more pain, just by looking at the images? B. I hear some B's. Some people are shaking their heads. A, because they think it's a trick question. So there's some people on to me. So yeah, this spinal cord looks pristine. There's plenty of cerebral spinal fluid around it. There really isn't anything in terms of disc herniation in patient A. In contradistinction, patient B has a number of pathology, maybe some spinal stenosis. Of course, as a radiologist, I'd read this as a normal MRI. This is an abnormal MRI. But it turns out both of these patients had 10 out of 10 cervical pain, right? And this is what I deal with on a daily basis. I'm charging $1,000 for each one of these studies. This patient is going home with some kind of report that may or may not help them. This one goes home with a normal report, which is totally useless, right? And we see examples of this all the time. And it's disheartening to see that what I do for a living lacks specificity and sensitivity, okay? Here's another exercise, all right? So you come into the emergency room with acute back pain, and then the ER physician orders an MRI, and they find this herniated disc on MRI, on your ER admission, okay? I want to know, in 6 weeks later, what is your most likely outcome, okay? You have two factors, so you have four possible outcomes, all right? Your back pain resolved, and if you have a follow-up MRI at that time, your herniated disc is resolved. The second outcome, you still have back pain, and you still have a herniated disc on MR, right? This is the other two outcomes. You still have back pain, but your herniated disc is now resolved on MRI, or your back pain is gone, and your disc is still present on MRI. Which is the most likely? The last one. But people are not playing along. It turns out all of these outcomes are equally likely, okay? Again, further, nullifying what I do for a living. I'm not exactly sure what I'm doing for these patients, right? I mean, my ability to call a herniated disc is not going to predict whether or not you have pain or whether or not you have an outcome that's favorable. All right, here's the last exercise I want you to do before I go into other things. You're 60 years old and above, and you get an MRI you have knee pain or you have no knee pain. What is your chances of having a meniscal tear, which is what the orthopedic surgeon uses as a reason to do arthroscopy and give you a meniscectomy, right? So if you have knee pain, you have a 63% chance of a meniscal tear. What is your chances, if you have no knee pain, what's your chance of meniscal tear? Okay, very good, very good. Yeah, this is exactly what the orthopedic surgeon or an internist uses to get you an orthopedic referral. Before you know it, you're in the OR getting your knee scoped, and for what, right? Obviously, asymptomatic patients have meniscal tears, right? I don't think we're looking at the right thing. And, I think the public is on to us, right? This is a New York Times article by Gina Colada, who writes a lot about this. Scans more sensitive and easily available than ever are increasingly finding abnormalities. They may not be the cause of the problem for which they're blamed. And then now more than ever, these imaging findings are sometimes even forming the basis for harmful treatments, including surgery, right? So including our patients who are CRPS patients who are going through the diagnostic challenge that it is, they're facing this too, right? A lot of what we say on our reports a lot of times might be normal, and yet now they're being described as crazy because we don't have an imaging finding to their disease, right? So I think what we're doing is imaging the wrong thing, okay? We're imaging anatomic changes, which time and time again through MR have been found not to be helpful. So what we need to do is do more functional, kind of molecular, preclinical and clinical imaging assays that can more accurately diagnose why someone might be in pain. And it really requires a combination of chemists, biologists, imaging scientists, neuroscientists, clinical scientists to develop these lead compounds and tracers. Ultimately, you want to use these imaging modalities to develop more relevant novel therapies, but also change the paradigm by which chronic pain sufferers are diagnosed and treated. So how can we do this? Well, I'm going to give you a strategy, and of course you've heard a lot of them today, so this is nothing to you. And I apologize that this is a very simplistic, this is the usual slide I show my colleagues who are the dumb MDs like myself. But I try to explain to them, okay, when you put your hand over a fire, you generate an action potential, and that travels to your brain, and that's ultimately perceived as pain. And the brain does a lot of stuff to modulate that, that phenotype. So, sorry, backing up again. There's a number of biochemical and molecular changes, physiologic changes at a variety of relay stations that we've heard about in the last couple of days. And so we can exploit what those molecular changes are using molecular imaging. And again, at the cellular level, on a single neuron, again, normal nociception, you have a given set of supportive cells around your neuron, and then schematically shown here, sodium channels, potassium channels, pain receptors. Again, very simplistic. I apologize. We have a very sophisticated audience. But in a normal situation, you have X number of these. And so in a chronically nociceptive environment or a neuropathic environment, you have upregulation in the sodium channels, in the calcium channels, in a variety of pain receptors. And that's what neurobiologists and neuroscientists have been finding. Additionally, we've recently heard from Linda Watkins and Aaron Milligan that we now have other supportive cells which are very critical to the nociceptive pathway. So for any given stimulus, now a chronically inflamed nerve is now sending a lot more action potentials, or signal spikes to the brain, signaling that you have chronic pain. So these are the type of things that we can exploit. So if we develop a tracer, radio label it with either a PET agent or a SPECT agent, and then administer it systemically, maybe we can find a way to map where these changes in density of the sodium channels, calcium channels, pain receptors, so on and so forth. So ultimately, as a radiologist, I would like to develop an imaging assay which can interrogate virtually the entire nervous system and then find where are these pathologic molecular changes along this pathway. And so, for example, if you're suffering from ankle pain or sensations of that, you may have actual changes anywhere along this pathway or maybe throughout the entire pathway. And it would be important, I think, from a therapeutic and a diagnostic frame of reference to know where these changes are, right? So let's say if we designed an agent and then we systemically administered it and then formed a PET MRI study, put this person in the scanner, maybe someone with ankle pain would look like this. That would be my dream image, okay? And, it'd be important to know there are certain centers, in the central nervous system as well as the peripheral nerve that are giving rise to this patient's source of pain. And then maybe, for the interventionalists in the room, you could direct your therapy right to the site of the nociceptive neuron, or maybe you would know exactly where to put the intrathecal pump, or maybe you do deep brain stimulation to take away these sites of increased activity. And as a strategy, I think what we're ultimately trying to find is what is giving rise to this electrical activity in the brain and the nervous system? We see increased excitatory, maybe decreased or increased inhibitory information. A variety of action potentials are changing. And we do that clinically right now, but a lot of these are invasive. And what we're trying to do is somewhat minimally invasive with imaging. And there are a variety of different modalities that we can look at, metabolic response that we heard today, like oxygen consumption in terms of BOLD, hemodynamic response also MRI can do, a variety of mediator response, so increased receptors, ion channels, neurotransmitters, cellular response as we've heard about, glial cell activity, macrophage activity. And all of these have imaging correlates. So for metabolic response, we have a variety of imaging modalities, including FDG, PET, CT, manganese-enhanced MRI, which I'll talk about later. Hemodynamic response, of course, BOLD fMRI does that. There's also O15 water PET that does that. Look at blood flow. There are a variety of mediators that we can look at, and I'll talk about one of them. But opioid receptors, cannabinoid receptors, serotonin receptors, neurokinin receptors, there are now radioligands available for all of these receptors. But none of them are being applied directly to pain just yet. And then, of course, we've seen a nice talk, our last talk talking about antibody-based imaging of cellular responses. And so, but you can also use iron oxides, as Dr. Koretsky talked about, to look at cell tracking methods. So here are some imaging examples. In my group, one of the things that we're very much interested in is the sodium channel. Much like neurokinin receptor antagonists, one time was the child of pain, if you will. Everybody's drug company was trying to develop a neurokinin-1 receptor antagonist. And of course, when the clinical trials started, those fail. But now the poster child is the voltage-gated sodium channel, and specifically voltage-gated sodium channel subtype 1.7. But there is now interest in using toxins as a way of one studying it and treating it, just like Botox is now used for a variety of pain conditions. There are a variety of sodium channel toxins that are being developed. And where do these toxins come from? Well, they're naturally produced by a variety of amphibious as well as marine animals. It's saxitoxin in particular is the one our group is interested in. And this is the culprit of the red tide. Are you guys familiar with the red tide? It's this proliferation of a red dinoflagellate in polluted seawaters, and people go and harvest their shellfish that they eventually consume in restaurants. And if you happen to eat a shellfish tainted with this saxitoxin, you will die of suffocation because your diaphragm freezes. It becomes paralyzed. But just like Botox is now used, cosmetically and now for a variety of pain conditions, if you titrate the dose of your toxin, maybe you can do something medically useful. So one of my collaborators, Justin Dubois, has been able to synthesize this toxin de novo in the test tube. We don't have to depend on a red algae to do it for us. And, apologize. If you do a patch clamp study, you can actually show that it has a very high binding affinity of 2.9 nanomolar. And you do a patch clamp study where you measure the rate of sodium ions across a channel. You can actually block that flux of sodium across the channel with increasing amounts of saxitoxin. And one of the neat things he found is that there's this carbamate side chain that you can exploit. And what I mean by that is if you modify it, it still retains nanomolar affinity. And that's kind of surprising because this is a very small molecule. Anytime you perturb a small molecule, you risk decreasing its binding affinity. But it looks like this side chain is not essential to the binding of this toxin to the outside pore of the sodium channel. So similar patch clamp experiments have shown that you can use increasing doses to block the flow of sodium ions across this channel. And then for grins, he stuck a big fluorescent dye on it. So this is Psi-5, one of these near-infrared dyes, and it maintained 32 nanomolars, an order of magnitude less. But if you put these in an axon culture, you can actually pick out with confocal microscopy single channel resolution in a cell. And if you take a real-time movie of this, you can actually show that these sodium channels are kind of moving in the membrane in real time. And right now we're just doing studies to study noxious conditions to see what happens to the distribution of sodium channels in the study. But this is what we're really interested in, is that, could you stick a radio label on this toxin? Now that you've been able to maintain nanomolar affinity by modifying this carbamate side chain, we did that by sticking a benzamide fluorine 18 molecule onto it and got decent yields on it. And we administered this radio-labeled saxitoxin in a neuropathic pain model. And this is the spared nerve injury, which is a widely used neuropathic pain model. Basically involves cutting 2 out of the 3 branches of the sciatic nerve, and then we go on to let the animal heal, and then we do von Frey testing to confirm allodynia in this animal. Eventually we anesthetize them, stick them into a scanner, and then inject our radio tracer and put them on our micropet, and subsequently get images like this, which I'll explain in a second. But here is a micropet image through the thigh of the animal after we've cut that nerve. And I'll go through greater detail. And this is a little fiducial marker that we need, because as soon as that part of the imaging is done, we have to walk over to the next room, which carries our 7 Tesla MR. And we put them in the 7 Tesla MR and eventually get axial images through the thigh. So what do those images look like? So here's our T1 weighted axial image through the thigh, and here is a normal nerve, which might be hard for those of you in the back of the room to see, but here's our neuroma that we created after ligating that sciatic nerve, and here's our fiducial. This is the micropet image, which now has this radio-labeled benzamide saxitoxin, and just by looking at it, you see some non-specific uptake, but then a lot of uptake here in the area of the nerve injury, and as well as this other area, which I'll explain in a second. And then we fuse those images with the help of our fiducial marker. And interestingly enough, or expectedly, we see increased radio tracer uptake at the site of neuroma generation. And there's this other uptake, which we didn't expect, because this is well away from the wound site of creating this model. And this is actually 5 weeks after the injury. We're seeing this kind of diffuse subdermal or dermal, as well as some muscular uptake of this tracer, suggesting that there is abnormal sodium channel density in these areas, which would not be too inconsistent with, or it would be consistent with neurobiologists have found studying this model. So we see a lot of sodium channel uptake in this model. I'm going to now move to a whole different example, glucose metabolism. So FDG PET-CT is now the workhorse for cancer screening and cancer staging, as well as follow-up of chemotherapy. But I thought maybe people who are in chronic pain may actually have increased metabolic changes in their nervous system. So why not just use what's already readily available and see if we can at least detect glucose uptake changes? And people have done this. Dr. Fiong and others in 2008 showed that if you did dynamic FDG imaging of the brain in patients that had chronic spontaneous pain due to left brachial plexus avulsion, you actually can detect hypometabolic changes in the right cerebral hemisphere, as well as hypermetabolic changes in the left rostral cortex, for example, or the dorsolateral prefrontal cortex. So a variety of changes are detected with dynamic FDG PET. Other investigators have used another analog of radio-labeled glucose, this one being 14C-deoxyglucose. And this is an animal model of adjuvant monoarthritis, and you can actually see in a control animal, these are autoradiographic slices again, and this is an animal with 14 days of the arthritis, and you can see increased uptake in the dorsal horn of the spinal cord of this animal with monoarthritis. So I thought, can we observe some similar phenomenon in living subjects with PET, FDG PET? And so what we did was just took 100 or so patients presenting for PET-CT, and these were all cancer-free patients by and large. And then we actually, if you look at the sagittal image of this human subject, you can actually see FDG going in the spinal canal as shown here. These are axial images with their representative levels shown here. And this is a ratio of FDG, or radiolabeled glucose, in the spinal cord relative to a background measurement. So these are ratios. And so as we march down the cervical cord, we actually see a pretty high amount. And then here's the cervical enlargement. So we see a relative bump in uptake at the cervical enlargement as we move down to the thoracic spine. Again, it's kind of descending in amount, 1.5, 1.0, and then we get up to T11, and all of a sudden it goes back up again. And just studying the cadaveric literature, you know that T11 is the site of lumbar enlargement. And if we actually look at patients who are suffering from back pain, so we have a group of asymptomatic patients and then patients with low back pain. This is at level T10 for both of these, and these are just representative images from one person in each group. An asymptomatic patient had a cord to background ratio of 1.2, and this person complaining of low back pain had a cord to background ratio of 1.9. And if you actually measure this and compare it, we actually get significance at levels T8, T9, and T10 in patients describing low back pain. So increased metabolic uptake in the part of the the thoracic cord that you would expect to see for complaints of low back pain. Kind of an interesting finding. Could this be applied to CRPS patients? Perhaps. Dr. Cooper and I were kind of talking about that as maybe a possibility. It'd be interesting to see what patients with acute flares or in pain have in terms of how much radiolabeled glucose they have in their cord. If we extend this to the animal model and look at our spared nerve injury, here's a axial image, MR image through the thigh, FDG PET image, and then our fused image. We actually see increased uptake in that neuroma, which is not too surprising. We also see uptake in the wound that's quite nearby. If we do a sham operation, we don't see any uptake in that normal left sciatic nerve. And then autoradiographically, if we harvest that injured nerve, we get quite incredible intense glucose uptake in that injured nerve compared to our controls. Also interesting in this study, we found that there were distal changes, so the injuries in the thigh, but their calf muscles had incredible and intense uptake. Probably some of it's due to denervation changes, but it would also be interesting to see in the human subject whether or not people suffering from neuropathic pain also had changes that you could detect with radiolabeled glucose in this manner. Calcium imaging, which is what I actually started out doing, and I was inspired by Dr. Koretsky. I don't know if there he is. So I when I was a young guy, which is not too long ago, okay, it was long ago, I started reading his paper. So before he was imaging single cells, he actually is considered the father of memory, otherwise known as manganese-enhanced MRI. And so I thought it was this brilliant idea that he had, where you could take manganese, which behaves very much like calcium, but the neat thing about manganese, it's a T1 shortening agent, so it actually has magnetic effects that you can detect using scanning. And what I just showed in that little cartoon is if you systemically administered manganese, it would follow the path of calcium. The interesting thing about manganese as well is that for some reason, and I need to talk to Dr. Koretsky after this, it's retained in the cell, unlike calcium. Calcium moves with microsecond changes across the cell membranes, equilibrating. It's involved in the generation of the actin potential. And then, 3 minutes, okay. So manganese is a T1 shortening agent. It can populate the cytoplasm of a cell, and it stays in there retained. And some work by Dr. Wang et al. In an animal that was receiving forepaw electrical stimulation. This is a control animal, and if you stimulate them with these shocks, you can actually get manganese to accumulate, which you can measure with MRI. I did left forepaw inflammation with CFA. This is a brain of a rat, and this is their cervical cord, and this is the asymptomatic control. This is the forepaw of the rat. This is the cervical cord of a rat, but this is C5, which innervates the forepaw, which was inflamed. And so we're seeing increased manganese uptake there, shown by the kind of white color. In the spared nerve injury model, you can see increased manganese uptake in the lumbar plexus. And this was a unilateral injury, and we're seeing kind of bilateral effects, which is a whole nother discussion for another day. If you hit them with an opioid, you actually tone down the amount of calcium, and they actually were relatively asymptomatic. So you could actually see the acute effects of opioid on manganese enhancement. And then this is an asymptomatic animal for control. It turns out there's this phenomenon called opioid-induced hyperalgesia, which Linda talked about yesterday. If you give an animal opioids every week, you can actually see progressive increase in manganese uptake and calcium uptake, therefore calcium uptake. And these animals would actually behave in more pain over time, having taken more opioids over time. So opioid-induced hyperalgesia is measured by memory. Another thing that we've done is to take iron oxide particles and mark the migration of macrophages. This is a work by somebody else where in an arthritic animal, you can actually see in the image of a knee that these macrophages, which have taken these iron oxide particles, have migrated to the synovium, and they're using that as a way of marking arthritis. But we've extended it to this neuropathic pain model. And this is a normal nerve in the T2 weighted image. So the nerve shows bright. If you administer this iron oxide preparation, theoretically, and we've shown histologically, which I'm not going to show here, macrophages take this iron oxide and they turn the nerve dark after the injury. So we see macrophage recruitment to the nerve injury. And then if you hit them with minocycline, you can actually retard macrophage recruitment to that nerve, and the nerve brightens back up to normal again. We do a little bit of TSPO imaging, which is another way to look at activated microglial cells. This is a infarct model, and we're seeing increased uptake there. Again, since I only had a few minutes, this is... Sorry. Yeah.
Which ligand is this?
This one is PBR06, which is being renamed as FBR. There's some problems with that, which I was going to go into. The TSPO imaging is a little bit challenging. We're finding subjects, as you of course know, there are patients with high-low mixed affinity binders for the TSPO. And I guess PK11195 is having a little bit of problem because it has trouble getting out of the brain once it goes in. So there's a lot of nonspecific binding and therefore a low signal to background ratio. So still, work in progress, but we're going to try to apply that to pain models. And this is a work by a UCLA group that looks like activated lymphoid tissue. So this is a normal animal. This is a tracer that has a proclivity for rapidly dividing cells. And in an animal with arthritis, you can see lymph node recruitment and as well as arthritic recruitment. And then you hit them with steroids, and then that lymphoid or that inflamed immune tissue just seems to disappear. I guess that'd be it. We talked about antibody imaging today, and Mark wanted me to talk about this whiplash injury report that just came out last week. There's this non-specific tracer. They have no idea what it does, but it earned them a publication regardless because they were able to demonstrate that people who had chronic whiplash pain were able to take it up in the injured part of their neck. And again, moving towards objective, functional, molecular relevant measures of pain. And then I thought because there was a lot of discussion about IL-1 and CRPS, IL-1 receptor antagonist that's been labeled with a SPECT agent has been performed in rheumatoid arthritis pain. What does it look like in CRPS would be very interesting and perhaps a avenue of study. So anyway, I've talked a lot about different imaging modalities. And again, thank the organizers for inviting me, and thank you. Yes. Yeah?
If you inject the toxin systemically, do you expect to see it in the dorsal root ganglion? And do you have plans to inject it intrathecally so you look at the spinal cord? And the second question is, how do you balance toxicity? Are the animals on a respirator when you inject the drug, the toxin?
So the first question is, so the challenges with this tracer right now is that it has a very fast off rate. So we're making new radioligands that will come off slower off the sodium channel. So given the size of a rat and the field of view of the PET scanner, we can't, unfortunately, we can't take one bed position and then move it up because the radio tracer is gone by that time. to answer your question. But that would be a separate experiment, which we're hoping to answer. So we would expect to see it in the dorsal root ganglia. Right now, this tracer we don't think will cross the blood-brain barrier at this time. Will we administer it intrathecally? Yes, eventually. Just the problem is, how do you get rid of background signal? Maybe we have to titrate it so that every single radiolabeled molecule does bind to something, and therefore it's not non-specifically binding, but that would be something we'd be interested in doing, for sure.
And how do you resolve the issue of toxicity if you want to move to clinical and in the animal experiments as well, since you mentioned it kills?
So this, we would only expect it to be in, well, as a radiotracer, we expect no toxicity because you're supposed to administer it at a dose which is well below therapeutic doses. So, and then we've done that with animals with no problem. As a drug, this is actually also being developed as a drug by our group, and so we're hoping that we use it as an injectable to the site of increased sodium channel density. So.
Richard. Sorry to make you show another slide again.
Right.
The C11 Gabriel that shows Mao beat. Just you were too fast for me to pick up. What did they find?
So, I mean, this is another similar story. This is a different.
No, the
TS
Gabriel, not this one.
I'm sorry. Oh, the whiplash. Sorry. I don't understand English very well.
Well, I can't speak it.
I understand American. Okay. So, I read this paper quite carefully, and one admitted they had no idea what the mechanism was, but for some reason they're seeing it, and it's approved in some countries.
Sorry, where do they see what?
They see. So this is the axial coronal sagittal image of a person who suffered from whiplash.
Well, that's a control on the left. That's normal.
Oh, right. That's normal. Yeah, sorry. And then this is someone with whiplash. So here's this intense focus in the paraspinal muscles.
Well, could be macrophages that have a lot of MAOB, which is what you would.
Yeah, that's one of the thoughts. Yeah.
Okay, good.
Yeah.
How do we take this information? The way you started the talk was, unfortunately the truism that as clinicians we see is, all that we see on an image isn't related to the patient's symptoms. How do we know that what we're seeing is not a more up-to-date version of that bulging disc that has no relevance to the pain?
That's a great question. So I don't know. I really don't. But I can go to bed at night knowing that I'm trying, right? And so clinically, I also do procedures. I do these pain injections, and they actually work some of the times because I got lucky, right? Right now, I don't have an intelligent way. I have to depend on the patient's subjective measures, their history, maybe some blood values if it was relevant. But when I'm injecting these things, I really, it's almost a shot in the dark, right? Here, at least, you'll have some objectivity to what you're doing, and then you can behave accordingly. So I would say, if you were to inject this site with lidocaine and his symptoms went away for that time, then I would say, okay, maybe we're onto something.
I would just encourage in doing this to remember the literature on provocative discograms too, and that
right.
was
Which is proven
in the
not
same
to be,
realm as well.
Oh, I totally agree. I would never do that. So, yeah.
I think we see a pattern here that there's a shift away from structural assessment to a functional molecular imaging. And the spectrum of successes that you're seeing there are cases where you can spot activated microglia, or in this case, the suspicion that that's a focal site of inflammation of soft tissue. So, right, as we examine all the complexity of these inflammatory processes, in this case, it's not necessarily neuroinflammatory, soft tissue inflammation, but it's a question of, as we transition into molecular imaging of inflammation, how do we blend it into diagnostics? Are any of the CRPS doctors here intrigued at being able to look into the spinal cord? Sanjay and I were talking, he suggested that fluorodeoxyglucose might be the best way to start. Any thoughts from the CRPS doctors on the biomarkers that they might be interested in? With the fluorodeoxyglucose, in somebody who had very intense regional pain, would you expect it to mimic what you see in the preclinical model?
I think at least in the periphery, I would expect to see it. So if we did a PET and an MR and then fused those images and tracked their nerves and saw increased metabolic changes in those nerves, I think it would give you a more intelligent, objective marker than what we have today, is my opinion.
Let me just clarify that. You're looking for markers of the peripheral nerve.
The peripheral nerve. Spinal cord is going to be a little bit more challenging only because in its basal state, it's already taking up radioglucose. So we'd have to see a dramatic shift or a different change in pattern of how it takes it up in order to come down a little bit with greater confidence. So.
Yeah, right.
So as a clinician, I would say that the value of doing this is CRPS patients have different kinds of pains. Just to give you an example, somebody with CRPS would have neurogenic pain, then they would have muscular pain, joint pain, bone pain, etc., etc. And using this modality, I could easily differentiate which part of this pain is as a result of neuropathic pain, the neuropathic component versus muscular component. If you can help us differentiate that, then I can target my treatment accordingly. So for example, if 60% of the pain this patient is having is because of the CRPS itself, the neuropathic component, then I can consider ketamine or whatever. And then if after the ketamine, whatever is left over looks like it's muscular pain, then I can target muscular pain. That's the place I would think it'd be valuable.
Thank you for that perspective.
Thanks.
Don?
I think what we really need from the clinical standpoint is a marker that shows changes with symptom changes in the patient. So that having a static picture of whether it is or isn't CRPS has, I think, some limited utility. But what would be fabulous is a functional marker that goes up with the symptoms, goes down with treatment, so that, I wonder whether a PET ligand is really the way to go, because you can't do repeated PET scans easily. That's something where you could do in a short time frame and actually be able to measure your response to treatment as an objective phenomena. That would be extremely useful as opposed to a static component.
I completely agree. Yeah. I mean, there are some optical methods that are being developed, but all of these optical dyes now will have to go through FDA approval in addition to the complex that they're being formed with. And, we're talking now 20 years before we see clinical reality. They have some optical tracers now for breast cancer, but it's already taken, a good 10 years to get them up to clinical trials. So I'm optimistic that will one day be one modality, but one of the big problems we deal with in the pain world is a lot of our pathology is behind bones. And so optical is going to have, just based on physics alone, a tremendous uphill climb to get around the bone information. And then there's this other modality called optical acoustics tomography, or another way, I forget what, it's a laser shining a light and you measure the sound coming back. But again, that also has problems transferring through bone. So.
You have time. Two quick questions. Eugene?
Thank you very much. Fascinating information. I wasn't around when, I was not a doctor when MRI was being developed, but I have a number of patients. It's kind of my hobby. I always ask a patient, what was it that surgeon told you when he convinced you to go for the disc? Very common thing was, he told me that I will be in a wheelchair like in a week. And things along those lines. When MRI, looking inside, enabled clinicians to visualize something. We made projection, and it sounds very drastic. So many. Are you taping? Oh my goodness. I'm sorry. So my question is there any way, do you think this technology will lead to something like this? Right now we think CRPS is probably in spinal cord, probably in the brain. This whiplash injury shows some speck in a cervical spine. Could it be something that we will eventually be telling people, look, you have this lighting up over here, therefore you need to have this $15,000 pump or $20,000 stimulator, otherwise you're going to be in trouble. Could it be parallel that same development, do you think?
Not sure I exactly understand what your question is.
Well, my question is, MRI led to a lot of new interventions.
Okay.
Now, this is completely new imaging. And right now, I tell patients, if you have symptoms in your left leg and your MRI shows disc bulge on the right, I'll just say it's not clinically relevant. We're not going to worry about it. Could something like this be the same way?
Yeah, just like I think earlier, I don't know exactly where it's going to go, but I'm hopeful that it's better. And as Dr. Giordano talked about yesterday, we have to be careful how we proceed and make sure we're not, hoodwinking our patients or referring population. So I'm optimistic. It's better than what we're doing right now. And I can't see voltage-gated sodium channels right now, but now I can, right? So I'm hopeful that it will be a better way to do what we do. So.